Good morning. Yay, good morning. So welcome everybody to the second annual Texas Public Health Summit. My name is Janelle Rios. I serve as the Deputy Director for the Texas Epidemic Public Health Institute, also known as TEPHI, as well as I'm a faculty associate at the UTHealth School of Public Health, which is right down the street here in the Texas Medical Center, the largest medical center in the world, and we're very proud of that. I have the honor of serving as your MC for today's event. To encourage us to take our seats and keep the program running on time, I'm raffling door prizes at the end of each break. Yes. And you must be present in the main room, though, to win. So take out the raffle ticket that's tucked neatly into your name tag. So TEPHI employees, we did not put a raffle ticket in your name tag. That includes you, Bob. I'm going to read the last four numbers of this ticket. Okay. You're going to win a door prize. Okay, so the winner of the first door prize is number 2033. Yay, excellent. And who are you with? What's your name? Kristina Mena with the City of Houston Health Department is our first winner of the day. Yay, thank you. All right. Well, now that I have your attention, allow me to share a few housekeeping items for those of you in the room today. The restrooms are located out the door to my right. If we experience an emergency while here in the room and need to evacuate the building, please exit the doors behind you and muster in the courtyard. This afternoon, we will provide lunch in the hallway to my left. At the end of the day, or sooner if you need it, we will give you a parking voucher. That way your parking is free. And we'll also give you instructions on how to use it because it is a little complicated. Additionally, and this is very important, we'll have coffee flowing throughout the day. So please help yourself along to the snacks that are right behind this wall here. Now we have an online audience as well. About 400 people are joining us online. So for those of you joining us online, we are recording each of today's sessions and they will be available on our TEPHI website in the next few weeks. To ask a question of our speakers or panelists, please type your question in the Q&A window. So it's just helping our online moderator if you put the question in the Q&A window. Our moderator will compile your questions and ask them at the appropriate time. Additionally, you may turn on closed captioning by clicking the bottom button labeled CC near the bottom of your screen. It's just now with these housekeeping items out of the way, it's my great pleasure to introduce Dr. Eric Boerwinkle, who will be joining us via video.
Good morning, everyone, and I'm sorry that I cannot be with you today in person. Thank you for those who are present today or joining us virtually for the second annual Texas Public Health Summit. The summit is brought to you as part of a collaboration between the Texas Epidemic Public Health Institute, the Texas Department of State Health Services, and the UTHealth Houston School of Public Health. When we set out to host our first summit in 2022, our purpose was simple: to create a forum for a deep discussion on a single topic of pressing need and relevance to contemporary public health. This year, we're highlighting the innovative science behind and public health applications of wastewater monitoring for infectious disease pathogens. The COVID-19 pandemic brought this science into today's spotlight, but the use of wastewater to detect infectious agents is not a new concept. Its application in public health dates back to the polio epidemic of the 1940s. Today, however, you'll hear about modern-day advances that offer the promise of providing an early alert system in the face of emerging pathogens and possible future outbreaks. It is our hope that today's event will spark new conversations and create bridges that will help further public health applications of this exciting and rapidly evolving science. I would like to give special thanks to Dr. Carlos Plasencia, Medical Director of DSHS Region 6, 5 South. I've had the honor of benefiting from Dr. Plasencia's compassion for the people of Texas and his wisdom throughout this pandemic. Dr. Plasencia and his team played an integral part in planning this summit and brought an important and valued perspective that a strictly academic committee would not have done. I would also like to thank Dr. Janelle Rios, Jennifer Deegan, and the extended TEPHI team for leading the charge to organize today's summit. While still early in its work, TEPHI has already made a positive impact on public health preparedness through its training programs, community collaboration, and as you'll hear today, its early detection work. With that all in mind, it is my great pleasure to introduce Dr. Jennifer Schufert, Commissioner of the Texas Department of State Health Services, who will officially open today's summit. Dr. Schufert earned her Doctor of Medicine degree from UT Southwestern, subsequently completing an internal medicine residency at Presbyterian Hospital of Dallas. She completed an infectious disease fellowship at the Mayo Clinic in Rochester, Minnesota, and earned her Master of Public Health degree from Harvard School of Public Health, something we're just going to have to forgive her for. Being tired of the cold, she returned to Texas and worked in Austin as an infectious disease physician in private practice prior to joining the Texas Department of State Health Services in 2017, where she served as the chief state epidemiologist. In December of 2022, Dr. Schufert assumed the role of Commissioner of the Texas Department of State Health Services. Under her leadership, the agency strives to achieve the vision of a healthy Texas and fulfill the mission of improving the health, safety, and well-being of all Texans. Please join me in extending a warm welcome to Commissioner Schufert, and please enjoy today's meeting. Thank you.
Thank you. So I do want to recognize Dr. Plasencia. Sir, will you please stand up? Thank you. So Dr. Schufert is unable to be here today. At the last minute, she had to stay in Austin. Taking her place is David Gruber, Associate Commissioner of Regional and Local Health Operations, Border Health, Emergency Preparedness, and the Texas Center for Infectious Disease. Please join me in welcoming him to the podium.
Good morning, everybody. Dr. Burwinkle, Dr. Rios, Vice President Deegan, members of the TEPHI team, and of course, Dr. Plasencia. Thanks for the opportunity to try to fill Dr. Schufert's shoes, although if you've ever met Dr. Schufert, you can see that physically her shoes are a bit smaller than mine, but obviously they're huge shoes to fill. So appreciate it. Dr. Schufert had planned on being here, and unfortunately, as you'd heard at the last second, she had to cancel the visit down here. But I'm here to, first of all, thank you for the opportunity to represent Department of State Health Services in being here. This is my second conference. I was here for the first one. Dr. Schufert was also here for the first one. And it's a pleasure to see this progress and to see this grow. Although I think many of you would probably be surprised to see so many in the room excited about talking about sewage. You know, that's sort of something. But the goal is to counter the IT adage of garbage in, garbage out, and in this case, have garbage in and data out during the day. So hopefully we'll be able to accomplish that. Last year was an interesting year for the conference. It was right after we were coming out of COVID, and we were just starting to reflect on the experience of COVID. And some of the things Dr. Schufert wanted to bring up were the facts that we truly operated as a public health system during COVID, and we need to look at how we operated at that system as we move forward. Some of you may be familiar with the term culmination point, and that's a period where, regardless of what size your organization is, how prepared you are, if you're faced with a large adversity, at some point you're going to run out of resources and you're not going to be able to handle that adversity because the adversity is so huge. So your options then are to quit, which nobody wants to do, or to look at that systems approach where you look to partners, you look to those who you've either dealt with before or need to deal with at the time, so that you can combine resources, can combine expertise and move forward and face the adversity, because the adversity isn't going to go away because you wish it goes away. The adversity is going to go away because you force it to go away. So that systems approach to public health, the interaction of the public sector, the private sector, the not-for-profit sector, governmental, non-governmental, all of those organizations working together are critical to the success of public health. The wastewater effort is sort of a microcosm of that. It's not just a public health effort. It's an effort of multiple organizations coming together to look at another surveillance and possibly response tool in the toolbox. It's interesting to look at wastewater surveillance. As Dr. Burwinkle mentioned, it's been used in the past, but also we want to make sure that we don't and this may be something that people argue, we don't want to fall into the same problems we fell into with BioWatch. How many are familiar with the BioWatch program? BioWatch program started right after 9/11 back in 2002-ish, 3-ish, and it was environmental air sampling, in which in specific parts of the country, there were air samplers that collected particulates from the air. In this case, it was the intent to look for bioagents that might be released as part of a bioterrorism attack. I will say that I found it interesting because back when I was 16 years old, I had the privilege of doing the pollen count for the city of Philadelphia. And every day at 3 o'clock, I would go up onto the roof of Albert Einstein Medical Center, and there would be 2 machines where I would take the microscope slide that had a gel on it, go back into the laboratory, stain it, and look for ragweed pollen, and then report out. And every day on the news, it was the pollen count of so-and-so. So I'm pretty familiar with at least the beginnings of biosampling. But if those of you are familiar with BioWatch, you'll also know that the city of Houston was the first time there was a BioWatch hit, and it was for tularemia. And most of you are aware that tularemia is inherent in this area. And there was actually no action taken because of that. The only time that there was multiple hits on a BioWatch system was on the mall in Washington, D.C., where 7 sensors detected it, but there was no action taken because of it. So the question is, with all this investment in a BioWatch system that has been going on for 20 years and actually no action taken on any environmental sampling, how can we make sure we don't fall into that same model as we move forward with wastewater surveillance? And having these conversations is very important to that, talking about the science behind it, talking about how to convert that science into action. Of interest, yesterday, CDC contacted certain organizations, to include our department, the city of Houston, and others across the country, about putting out an MMWR regarding wastewater surveillance. Particularly, they're interested in the timeliness of it to get some funding, perhaps from Congress, and we'll see where that goes. So there's significant relevance to this conversation today. The experts who are on the panel are here today to discuss it. I look forward to hearing what they have to say, and we should all look forward to always looking for opportunities to increase our capabilities and abilities within public health, to do it in a coordinated way, to combine science with operational practicality, and make sure that we're able to best protect our populations against public health threats, and should those threats emerge, be able to respond to them. So thank you very much for the opportunity to speak with you to start this. I wish you all a great conference today. I look forward to hearing about things. And with that, since Dr. Shuford was supposed to officially kick off the conference, in her absence, I will officially kick off the conference. So thank you.
Thank you, Mr. Gruber and Dr. Boerwinkle, for such a warm welcome. The collaboration between the Department of State Health Services and TEPHI benefits Texans in an incredible, meaningful way. Today's summit is titled From Sewage to Solutions: The Possibilities and Implications of Wastewater Early Detection. We will discuss the possibilities this morning and the implications this afternoon. To lead our morning discussion, we are honored to have Dr. Anthony Maresso present our morning keynote address and then moderate a panel of experts who will discuss the possibilities from diverse perspectives. So let me introduce Anthony. Dr. Anthony Maresso is the Joseph Melnick Endowed Chair of Molecular Virology and Microbiology at Baylor College of Medicine. He acquired his PhD in genetics from the Medical College of Wisconsin and did his postdoc fellowship at the University of Chicago in biochemistry and microbiology. His research operation currently employs 22 PhD students, research fellows, and technicians whose topics of study span vaccinology, therapeutic development, mechanisms of mutagenesis, organoid biology, the origins of life, directed evolution, and viral detection. He is the recipient of the Baylor College of Medicine's highest honor in mentoring and teaching, former co-director of 3 graduate school courses, and former inaugural Baylor College of Medicine senator. One way faculty are measured is by the amount of funding they bring into their institutions. And Dr. Maresso has generated more than $35 million in funding. Impressive. In 2019, Dr. Maresso founded a Baylor-based not-for-profit center named Taylor Labs. The objective of Taylor Labs is to evolve personalized antibacterial viruses for untreatable deadly bacterial infections. Excuse me. During this year, he founded a biotech company called Phiogen to advance inventions and therapies developed in his lab. Pardon me. In his spare time, I'm not sure what that might be, he has authored more than 70 scientific papers and is the sole author of a leading textbook in the field of bacterial diseases called Bacterial Virulence, a Conceptual Primer. Finally, and this is how we know each other, Dr. Maresso is the principal investigator of the newly formed TEPHI, Texas Epidemic Public Health Institute's wastewater monitoring program, also called TexWeb, which aims to detect the human virome from wastewater across the state. His hobbies, he has time for them, include spending time with his 3 sons, as well as camping, kayaking, woodworking, fishing, and sailing. Please join me in welcoming Dr. Maresso to the podium. So right quick, your timekeeper is right here. She will give you a 5 and 1.
Okay. Can I wear this? They said
Oh, yes, you can.
I'm like a 46-year-old toddler. I can't stay in one place. So if I could walk around. Is this working? You guys can hear me good? All right. If this advances. So Janelle, it may have been just easier to say he has attention deficit disorder, which is sort of sometimes what I think I do have. So I'll just get right to it. The title of today's talk is Sewers to Solutions to Possibilities. And I'm going to try to break this as broad as I can to keep you all interested. So there are some goals for the talk. The first goal is to talk about the history and concept of this field. And that's because we have diverse learners in the group that I think should be brought up to speed on that. The second is to talk about the rebirth of the field. Now, those that are in this field will say it never really went anywhere. But as Dr. Borwinkle said in the beginning, the COVID pandemic really brought it to the mainstream. And then finally, we're going to talk about what we're doing moving forward. So some expansion and innovation around viral detection under the auspices of the TEPHI Wastewater Consortium, which I'll introduce to you, including using the human virome as a proxy for this science. And then we'll leave the questions for the panelists. So let's get into part one, history and concept. So in 1939, there was a plane that left Detroit, and it was leaving Detroit because it was sent there to pick up some wastewater samples from Detroit. They had a bad polio outbreak. These samples were being sent to Connecticut, to the laboratory of John Paul and James Trask. And what they intended to do was to ask whether or not that sewage that they picked up in Detroit, when injected into monkeys, could cause polio disease. And in fact, it did. And they reported that in this paper in and around 1940. And it states right in the paper that it occurs to them that within the city, there must be ample opportunity for the virus to enter the local sewage system. And so when they proved that the monkey developed the disease, polio, this was basically the birth of what we call environmental virology as it relates to wastewater-based epidemiology. So now fast forward 20 years later, bring us to Houston. We had a problem, actually a really bad problem. This is a child who has polio. He's in the iron lung. And in fact, in this city, there was statewide 25% of the cases of polio from 1945 to 1955. And as a result of that, the first polio respiratory center was formed right here in the fledgling Texas Medical Center. And that's important because it led to the recruitment of Dr. Joseph Melnick to Baylor College of Medicine. He was a polio researcher. He was the first chair of the Department of Virology, and he was helping develop the oral polio vaccine. But he also understood wastewater sampling because he had worked with the team at Yale. And so what happened was he brought that science to the city of Houston. He had been doing it since the 40s. And in the summer of 1962, he observed that the virus was increasing in wastewater samples from Houston. They had planned to introduce the oral polio vaccine that fall, but he convinced the public health authorities to push up the introduction of the vaccine by a full 5 months to get ahead of what he thought was going to be an outbreak. And that is really the first demonstration of using such monitoring for the good of public health. Okay, now the problem with this science is that it requires extremely sophisticated technology. So this is the capture device for all the samples that eventually make their way to us. So it all starts here. This is a 500, roughly 400-year-old invention that when it was invented actually reduced communicable diseases substantially in England, so much that they mandated in that country as a public health act that everybody should have one of these. And that is why we're really here today. But the premise is really simple. So you are a pathogen incubator. Pathogens grow in you. They use you to make more of themselves. You are then a pathogen dispenser. Everybody kind of became familiar with that with aerosolized release during the COVID pandemic, but enteric diseases release pathogens the other way, right? And if you can get to where the pathogens are dispensed and collect them, you have a wonderful resource for their epidemiology and etiology. So what I'd like to call the sewer to solution cycle based on sort of the theme of this is here, so we can all kind of appreciate this. There's a public health situation, so some type of disease or infection, and it's affecting a community. Now, in wastewater-based epidemiology, we're here for really kind of for pathogens and virology, but the truth of the matter is that this has been going on for monitoring substances, carcinogens, pesticides, other biologics, hormones, nucleic acid, RNA, DNA, for quite some time. And so all of these are possible to be measured in wastewater. It's, of course, delivered to the sewer system through your involuntary donation. The sample is then acquired, and the beauty of this is that you can, because of the modern sewer system, whether you're in a community, in a hospital, or a school, or wherever, you can pick and choose along the way where you're going to take the sample prior to it getting to the treatment plant. And then, of course, there's also reason to sample after it gets treated, so you know that these things have been removed, right? In WBE, there's a processing step and a testing step, so it comes into the laboratory. There is some data analysis and modeling. And then if that is all done well, hopefully there is the ability to make a public health decision based on that knowledge. And then we have a healthy community, right? So that's kind of how this works. What I like to do is think about this as a health visit, but for millions of people. So what I've put on the top is that, like, you go in to see your physician, you're an individual patient, you provide a sample, you have a test, there's a report that's made, the physician will make a diagnosis, and then there'll be action, give you a therapeutic or something. For WBE, the patient is the population. The sample is, of course, the use of the restroom. The test usually occurs in a laboratory with the more sophisticated technology. The report you could think of as like a trend or a trend diagram, or these various infection curves that we've seen during the pandemic, but it's for the population. The diagnosing physician in this case could be viewed as the public health department, and then the action can be taken, either education, intervention, or some other suggestion. So another way to think about this from the individual is you have individual tests, 10 infected individuals. If this circle represents the population, you're only seeing a snapshot of the disease in the community, and those that are basically self-reporting, right? So what is clinically invisible is all of, in the case of pathogens, viral or bacterial dark matter that you don't detect there. Wastewater testing fills in that gap. So here, the red is now rendered in the literature, sometimes described as being rendered visible. That is, we have a more comprehensive picture of the agent in the population. And if you have a geospatial grid to where these samples are being taken from, then you have resolution as to where that agent may be. And that's really the power of this approach, right? So where does it fit in the public health framework? I would argue it's part of the foundation. I took a World Health Organization document and just modified it a bit to show the health pyramid. So on the bottom, the base is prevention. The best cure is preventing the disease. Monitoring is sort of the second level. And then all of care for patients are sort of up the pyramid, right? So I would consider wastewater testing somewhere at near the base of the pyramid at the bottom of the monitoring step, and clinical testing just above that. Okay, so what is the good, the bad, and the ugly of this area as it stands now? The good, it's relatively unbiased. Population level data, as I've emphasized, cost effective, very cost effective when it comes to public health. Universal self-reporting generally. Relatively non-stigmatizing. So if you're an individual and you get diagnosed with a disease, it can be stigmatizing. I would argue this is less stigmatizing, although for some agents, maybe for communities, it can be stigmatizing, but relatively non-stigmatizing. And you have a comprehensive picture, and there could be seasonal or temporal trends in diseases. The bad, I would argue so it's good and bad, it's double-edged sword right now is there's a lot of hype around wastewater-based epidemiology. And that's good because it's going to bring attention to the matter. But I think you have to remember that it is just one part of the public health armory. It is not a solution to all public health problems. It's one tool that we're going to use. It does render the individual invisible. So it's very difficult to get, although it has happened, it's difficult to get to the level of the individual. We're still learning. We don't really have enough support for this field, I think, to do what we really need to do. Expertise is growing, but somewhat limited. And there is a ton of data that is generated. And sometimes the analysis of the data is the bottleneck, right? Okay, the ugly, prevalence. So like a disease you think is in a community, how many people actually have it? It's very difficult to make these calculations, and it depends on not only, say, for a virus, the individual virus, but the chemical composition of the thing you're detecting, as well as all other factors that are environmental, personal. Privacy, so there's some concern that this could be viewed as surveillance and intrusive. Politics, that is because there are multiple entities in play. And the pipeline, who talks to who? So no one person can do this in their laboratory. It is a congregation, as you will see, of many people along a pipeline, and they often speak different languages. They are often siloed physically, and you have to connect them together. And then policy, maybe the biggest challenge for all you public health epidemiologists in the crowd is how do you act? What do you do with this information? These are very difficult questions to answer. And we have panelists in today's afternoon that are going to try to get at some of that. It's a very difficult job. Okay, it's not like this science is new. There are societies out there that think about these questions, and actually there's some really good reports that came out, and you could read these and learn a lot about this field. So a lot of these things are addressed in these publications. So what is sampled in WBE? So you could break this down into two areas: substances, so chemical compounds, small molecules. They could be narcotics, they can be pesticides, they can be prescription drugs, they can be carcinogens, right? But the point is that usually the detection of those chemicals is a very specialized process. You need a highly sophisticated technology that is usually specific for that chemical structure to be able to detect it. For everything else, for life, for cells, there's a benefit here in that we all share one thing, which is nucleic acid. And nucleic acid has a very similar structure, just changes 4 letters through most of life, right? And so structurally, the detection of this technologically can be amenable to a universal target. So there are some techniques that can detect most all of nucleic acid. And that is a real benefit here for monitoring pathogens for WBE. There are other reasons we're concerned about what's in wastewater. It's not just for health benefits. I would argue a larger part of the field is sort of sampling for health workers at utilities, runoff into the environment, and water recycle risks, right? We have representatives from El Paso here. 100% of water is recycled. You have to make sure that it's clean as it's recycled, right? Okay, how did we get to this moment? Rebirth. So here, we're just gonna focus on mostly COVID to get us how it came more or less to the mainstream. And we've been working on wastewater science for about a decade now. And this was the way we used to do it. We just literally go to a plant, dump a bucket down there and pull it up, pull as much as we can back. And our job really is to find, we like in the laboratory to find new microbes. We love new microbes, we want to study them. We try to make them pure so we could study them. I would classify us as microbe hunters. And one of the things that we specialized in for about a decade is finding viruses called phage. We use these phage as actual therapeutics. They kill bacteria. And some of the phage that we've treated people with and saved their lives in our clinical trials actually came from wastewater. So wastewater is also a source of novel medicines or novel therapeutics. But because of that science, we kind of learned a few things about how to isolate viruses from this very complex material. And so when the coronavirus pandemic happened, we, like everybody else in public health, asked, what can we do, right? And so we knew from some literature, SARS-1, there's evidence that this virus infects cells of the gastrointestinal tract. For SARS-2, lots of evidence that there are gastrointestinal symptoms. This pointed to us in the direction of that it might be possible to, just like polio, to monitor SARS-CoV-2 in the sewage system. And so we had some samples. Again, we were trying to find other viruses from early in 2020, January, February, March. And we asked our colleague, Dr. Pietro, who had just formed a testing center just down the hallway from us, can you test some of these sewage samples for SARS using the newly approved FDA primers? And they did, and there was a eureka moment. We had a hit right away. And that's actually the email, April 22nd, from Vasante, who's in the audience. And I realized right away, it's like, there's something, we can do something here. This is a moment scientists dream of, right? That you have a result where you can see where it's going to go. But we needed a good sampling network. And I kid you not, a week later, Dr. Lauren Hopkins at UTHealth sends an email to me saying, I heard through the grapevine, you're sampling for viruses in sewage. Do you think we could send you some samples on a regular basis because we want to build this, just so that we can do this at the start of the pandemic. They had the foresight, and you're going to hear about this in the afternoon, to install these sampling systems basically throughout the city of Houston. And I think it's one of the more sophisticated networks that I know of, and is really a game changer for being able to do this science really well. Not too far after that, Dr. Mena contacted us from El Paso, wanted to do the same thing. She's very much patched into the utility there. And so we were getting these samples on a weekly basis at the start of the pandemic from Houston, 39 sites, 4 or 6 sites from El Paso. Now I'm going to take you through how we sort of detect the virus. There's a lot of sort of innovation, but also problems, at least initially associated with that. But bottom line is we developed a pretty good assay to detect it. And then simultaneously, the city was sending samples to Dr. Stadler at Rice. She's also in the audience. She's a panelist in the afternoon panel, so please come for that. So we had 2 laboratories, independent laboratories at the same time surveying for this virus, sometimes using different methods, sometimes using the same methods. That created a powerful tag team on orthogonal validation to detect the virus. And that was fed into Dr. Enzer's team. She put together some remarkable models and statistics to basically make the data believable. Dr. Clark from my team contributed a little bit to that. And this is the cycle that went on for 15 months, basically, during the start of the pandemic. And we learned a few things. So this is a heat map of when you see red, that's an increase in viral levels. And so you could see the early 2020 summer outbreak that we had in Houston is just blazing hot, right? We saw that in the wastewater. Dr. Enzer was able to correlate very quickly clinical case data to the wastewater data. I'm going to leave it at that because it's advanced so much farther since then, and she'll tell you about that in the afternoon. She's a panelist. But basically, it was obvious that this was going to work, right? That this was real. One of the really cool things that we saw early on was if you look at positive case data and wastewater data, it didn't really look like they overlapped. Like how is it a lead indicator? But what happens is that you have to fast forward the wastewater data into the future to match the clinical data. And when you do that, then it overlaps. So the wastewater data, the early stages was about 10 days ahead of the clinical case reporting data, which is a really cool finding. And now this has been demonstrated over and over again. It's pretty good in being able to predict or forecast admissions and hospitalizations, et cetera. And you could see here that it has a lead time. And it's blown up, right? So many people have entered this space, and we weren't the first. At the time when we saw that observation, I Googled it, and it looked like we were. I didn't see anything pop up, but there's actually 2 groups in Europe, so one in the Netherlands that in March had been sampling and showed that the virus. But this has become now a worldwide phenomenon, and I've just highlighted some key studies that have really defined the field here. And one of the panelists today, Dr. Gerba, is here. He actually led a study that showed that you can do this for college dorms, and you can actually pinpoint the individual or the site of infection in a college dorm. So that's the level of resolution that sometimes we can get. And it was nice. We got to do a little press conference with the city of Houston. That's Dr. Stadler on the left, Dr. Hopkins in the back, Dr. Peirce on the right, and Stadler and Dr. Peirce will be here in the afternoon, so stay tuned. Just a little fun fact. Like I told you, I have attention deficit, right? So, there's 100 billion stars in the Milky Way. We calculated that we detected 1 quadrillion viral nucleic acid particles, which if that's 1 to 1 molar with viruses, that's a lot of SARS-CoV-2 made by us. But what it does is, and this is why I'm a microbiologist, it shows you just how powerful and in tune these pathogens are with what they want to do, right? Their job is to replicate. They use us to do it. And this virus, did that very well. There's a national wastewater surveillance system. This is a wonderful development. The CDC is running this. It's September 2020. Right now, they're receiving 1,000 roughly samples. I think every 2 weeks they've shifted to now. And there's a contractor running these samples to analyze for SARS-CoV-2. Okay, part 3. I think for this, I'll switch to the other side of the room just to give people over here a little bit. All right, so this is, what are we doing now, right? Like, where are we going? Disease X. So the next pandemic, there will be another one. Hopefully, maybe not in our lifetime, but this is how nature is with these viruses and these bacteria. How are we going to detect it? And so there's been some reports that there's multiple pillars of this. And pillar 3 is about using sequencing technologies to detect infectious agents for all species in the same laboratory system. And so we're going to tell you about that. Our ending of the STARS work coincided with my introduction to Dr. Boerwinkle, who had a vision that we might be able to do this work through TEPHI. And so he and Dr. Rios and their team were able to create this wonderful institute to sort of think a little forward in having a monitoring network in place. So we had to build a plan, team, network, science, and a product around total virome analysis, right? So this is the end-to-end pipeline, sometimes called in the literature, but effectively on the left here, we have a plan for how we interact with utilities. We provide them SOPs, for example. We cover the cost of shipping of samples, how we interact with public health departments to get people in the network. So that's on the left. And then there's a science part, which is really about the laboratory detection. That's in the middle here in the orange, and an analysis part. And then on the right-hand side, there's downstream public health action. So what do we do, right? If you want to read a little bit about this, there's a nice paper that we put out, sort of outlining our vision for how to do this. This is the current team. We call them the TEPHI, or Texas Wastewater Consortium. It's an open-ended invitation to join the team. We want more people to join so that we can build this science together. This is the network. So we have utilities on the left. We have academic institutions in the middle, and then public health departments on the right. So this is actually the flow of sample, it turns out, right? So left to right. The consortium has 3 working groups that work on specific problems. The validation group is led by Fuqing. Basically, they ask the question, what do we know? Is it real? The data analysis group is led by CC Bauer. What does it mean? And the action group, I put it with exclamation points, like do something, is led by Jennifer Deegan. In other words, what do we actually do? And I would argue that is the most difficult part, is the right side. But the science and the analysis is also very challenging. So this is the network. You could see that geospatially we have, I think, Texas covered pretty good. We could use more sites in the valley and then on the east. But basically 21 catchment areas. I think it's 10 cities. I put here 7 because there's some cities around Houston. Houston's so big that it kind of blocks them out. But these are the cities in the network. And Dr. Mena has been instrumental in with John El Paso Water and getting people to onboard into the program. This is about 16% of the population. And we have openings, so we wish for people to join. Okay, so you have complex material, you want to get it down. The key is to get it to nucleic acid, universal detection target, right? So we have a program where we do targeted viruses. This is run by Dr. Piedra. So 14 viruses using PCR, just like we detect SARS-CoV-2. We have a respiratory panel, an enteric panel, a vector-borne panel, vaccine preventable panel. But the other part of this that we're really excited about moving forward is what we call the agnostic part. That is the sequencing, or the comprehensive part. And there we have the ability to detect, in theory, 3,500 different mammalian viruses. So basically everything else, possibly disease X. These are two orthogonal, right? So we get data goes to, or sample goes into both, you get data for both, and then you can cross compare, right? It's a good way to validate. And then we have an analysis team that is going to put out the data. So there are some people skeptical about sequencing as a monitoring platform. And I put the slide in here to address that because people see it as a coding platform, right? Like you determine the code of an organism. But in sequencing technology, you amplify the sequence in order to be able to read it. And that amplification is quantitative. So on the y-axis here, these are reads coming off DNA. We can use that mathematically to assess roughly how many copies of something is there. And then because you have sequence information, you also have the X, and that gives you specificity. So in one reaction, a single reaction, you have quantification and you have what it is. That's very powerful. So we produce a report. We've been doing this now for about a year. This is what the report looks like end to end. It's a pretty cool report, I think. And we send it out to the public health departments and the utilities in the network. I'll just take you through this. This report really developed from a group that came together and brainstormed what it should look like. But three people that are instrumental are Mike, Sarah, and Joanne in helping put this together. In particular, Mike, who's in the room, is the Brad Pitt of computational biology. So he is largely responsible for a lot of the conversions here to the graphs. He's just a whiz at it. So in the report, we show the sites involved. We have a schematic to sort of when people were onboarded and how many samples. And then we go right into the PCR right away. So the targeted approach is the first thing people see, right? So here you have influenza virus, SARS, et cetera. This is from the past year. And then we have the sequencing part, right? So that the second method that we're using, and there are viruses that I'm showing here for that. The beautiful thing about this report is it's toggleable, it's interactive. You're gonna have a drop-down menu, type in the virus you wanna look for, and it'll tell you if it's there, right? It's an interactive tool for knowing. We report the data in many ways. So percent change from last week is one way. So for example, we had an 800% increase in norovirus from last week at this one site. And I'm just blocking the sites here so there aren't concerns about sort of like what's happening in communities and stuff. You can go in and because we have read data, again, sequence data, for some of the viruses, we get 99% coverage of the genome. So we can tell you exactly what virus it is. And you could go and analyze that data and cross-reference it against what's in PubMed or GenBank, et cetera. And then we tell you how to interpret the report, show you some methods, et cetera, offer consultation if you want it. Okay, in the last part here, I'm just gonna focus on some really cool things we're seeing, right? Just to show you that I believe this is the future of pathogen monitoring. So these are human adenoviruses. I think there are 21 on here or something like that. They cause human infections. They cause gastroenteritis, and sometimes they cause upper respiratory infections. They're not on really the clinical monitoring network, yet we're seeing them spike and go down on a weekly basis at different sites, right? So what are these doing to public health? Well, we're seeing them, and so the extension is now the dark virome is being revealed, right? So that's how I started. Here are some known viral pathogens. My glasses, I can't see. Enterovirus D68, that's on people's mind. You can see we had a summer spike last summer. Hepatitis virus, monkeypox. We saw monkeypox right away. It wasn't really, it was doubt as to whether it was believable. Because it was just so amazing that we're seeing it, but monkeypox was picked up by this. Influenza virus A and B, so H1N1, H3N2, human viruses, many different noroviruses, RSV, right? And of course SARS, right? The star, which we benchmark against actually the data because SARS is now well accepted. Okay, I'm just gonna get right to the point. Does it work? Proof sort of in the pudding is like, well, does it correlate to clinical case data? And the answer is yes, right? You can use sequencing technologies, correlate to clinical case data. Here's influenza case data. Here's the virome sequencing wastewater signal. They look like they're pretty close. I just don't think that that's an accident. The correlation is really good. What about enterovirus D68? yes, the correlation looks to be real, and it in fact is, right? So SARS-CoV-2, monkeypox, wherever we have clinical data, it matches with our data, right? So we think that this is definitely tracking these. Okay, on any given week, we're detecting about 500 different viruses. You could see that as number of plants get sampled, we are sort of approaching saturated. There's not an infinite number of viruses. It's cool. We can monitor viral evolution. This is human adenovirus 41, causes gastroenteritis in children. In El Paso, it's evolving differently than it is in Houston, right? So the virome is evolving locally. That's really neat. You could do it by family or genus or however you want. There's unique species per se, not just strains, but entire species. And then I think this is one of the very telling things. This is 2 cities. Houston is in the red, El Paso is in the blue on the right. This is total virome signal in space and time put on one graph. Each city has its own signature, much like humans have their own microbiome signature that's diagnostic of them. They have their own unique viromes. Just fascinating, right? Okay, last thing here to leave you with the concept that you might have a total seasonal virome. So we've been talking about this for years, thinking that this is real. People know about influenza season. There will eventually be a SARS-CoV-2 season as it becomes fully endemic. But Mike found a way to put the entire virome signal together in a way that you can see over the course of a year. And it looks like it's returning back to where it started, right? Which is just absolutely fascinating. So you can watch it play off again. We don't have full year data for all the other sites, but if you put them on here, Lubbock was the 3rd one to come on. It looks like it's turning too, right? And if this turns out to be real, what it implies is that these viruses have found a way to sink themselves into the human population at specific times of the year, and they've been doing it for a long time, and they stick to that periodicity. That means you can predict it. That's important, right? Okay, there's gonna be a paper out on this soon. What's next for this field? So to close, I think you can do most pathogens that are found in human intestine, many pathogens that are found in your body. So bacteria, fungi, parasites. We have evidence we can detect tuberculosis and HIV, which hides itself in cells. We have evidence we can detect that. I think it would be amazing if we can actually put a laboratory in the sewer system so that when we have a detection event, it's real time and it just comes to your phone, right? It takes about a week to get all this stuff to the lab to process it, the data to be analyzed, right? Wouldn't it be amazing if we had entire utilities that have labs built in ready to do this? Multi-omics, some people are already doing this. So proteomics, transcriptomics, right? For cancer, diet, immunological status. I think you can predict neutralizing antibody status by wastewater data. We're going to try to do that. So maybe next time I talk, I'll tell you about that. And then machine intelligence. There's so much data. Let's get the machines trained on the data so that they can basically predict what the viruses are doing or see patterns that we can't, right? Get ahead of it all. On the public health side, I think we need advocacy, not only for research in these programs, but for communities to understand this work. We need guidelines, science analysis, messaging, and action. One data. So the one data idea is that you use multiple data sets, orthogonal data sets to validate a hypothesis or to take an action, right? So clinical data, wastewater data, electronic health data, all together in one would be powerful. And then finally, the next slide, we need unity. So this is a field that, like I started with, is very siloed. You have utilities, you have runners of the sample to a laboratory, you have people that receive the sample, you have people in a line that are processing the sample, and then the data goes to analysis team, and then hopefully to a public health department. The public health department then has to somehow transmit it to people, right? So, I find it kind of ironic that the thing that we're trying to get rid of the most actually in the end comes together and mixes in all one place. And that's why I put there's a little bit of all of us in these samples, and we just have to find a way to mobilize that theme for the good of public health end to end. So I'm going to stop now. I was told there's a 5-minute break, and then there'll be opportunity for questions with the panelists, which I'll moderate. So thank you. Oh, I can't believe. So I tried to really give everybody credit during the presentation, but the laboratory itself is, is an amazing group of people, some of the funding sources. And then I have the privilege of working at Baylor College of Medicine to give me the freedom to explore things like this, even getting my hands in sewage. So you guys already know me, but you may not know the rest of the panelists. So the first thing we're going to do is give them an opportunity to introduce themselves and maybe give a little background into how they're connected to this field. We could start, I guess, with Nicole. We can just go this way.
Sure. Good morning. Hi, I'm Dr. Nicole Brathwaite-Dingle, and I have the privilege of serving as the Deputy Medical Director and alternate local health authority out at Fort Bend County Health and Human Services. Also by background, I am a board certified pediatrician, public health trained clinician. Spent many years in primary care. So many of these pathogens that Dr. Maresso was discussing was very exciting to me because I saw them in clinical medicine, pediatric medicine all the time. I told him a background is I'm a biology major undergrad and a big science nerd. So this makes me very happy. And currently I have the real privilege again of working with our epidemiology team out in Fort Bend County and with our local health authority where we use this science to inform our work and help make decisions. I'm really pleased to be here today.
Good morning, everybody. My name is Heidi Boyes, and I'm the Director of Environmental Epidemiology Disease Registry Section at the State Health Department, Texas Department of State Health Services. And we have piloted a wastewater project over the last 2 years and are transitioning to expand the project to include more municipalities and more pathogens.
Oh, I got one here. Is it on? Yeah, thank you. Yeah, I'm Chuck Gerba. I'm a professor in the Department of Environmental Science at the University of Arizona. And my background is basically environmental virology and wastewater monitoring for viruses, which I actually started doing here at the West University sewage treatment plant back in the 1970s. I never realized by all the viruses we were getting, we were finding out what people actually were infected with all the time in that. But it actually has a long history at Baylor College of Medicine, wastewater monitoring for viruses.
Good morning, everybody. I'm Amy McGuire. I'm the Director of the Center for Medical Ethics and Health Policy at Baylor College of Medicine. And I conduct research mostly on ethical and policy issues related to emerging technologies and novel therapeutics, and have done a lot of work in the area of human genomics and also was involved in the Human Microbiome Project. So I'm thrilled to be moving into viruses with all of you, and have really had the pleasure of working with Jennifer Deegan and Eric Borwinkle and Anthony and some others around thinking about the action working plan group and disclosure of findings to public health officials as well as the public.
Okay, so what we're going to do is we have a few prepared common questions that I'm going to ask just to start us off. And then we're going to open the floor in this room in particular to questions from the audience. And then we will jump to questions online. So we'll try to even it out in 3 parts. If it's okay with you, Nicole, can I start with you?
Sure.
So one of the questions that commonly comes up, and this is, it's obvious this is a very difficult question to answer, but we got the right people here, is how do you package wastewater data in order to communicate results to either the public or other public health officials?
Yeah, that's a great question. And I will start by saying that, we take a page out of your handbook, which was, I thought he did an exceptional job of breaking down the science, right? We often are speaking to non-scientists and non-clinicians. So I think there's a basic tenet in public health communications, which is know your audience, right? Who are you communicating with and how are you going to frame your message? And so you did that really beautifully on just one slide of really breaking down the science and making it understandable. And then, who are you speaking with as alternate local health authorities, public health officials? We're often tasked with making this science relatable to elected officials of municipalities, and that might take the form of briefings and reports, right? Always providing that background science, making it really focused is so that they understand the background of what you're doing, and then telling them how it applies and relates to their decision making. And then if you take it to the public, how does the public look at this information, right? Most of the folks walking around are not scientists. How does it relate to them? I think the city dashboards, I look at Houston Health Department's dashboard is typically how many municipalities have done that, right? They make it really easy to understand using things like the heat maps, using things like line charts, and explaining to folks that we're looking at trends in data. And then how and when will you message is also the big piece. We don't want this to be background noise for people that they'll tune out. So we really want them to tune in when we need them to, maybe when we know an outbreak is imminent. So that's, I think, a little bit about what I would say about how we make it understandable, relatable to our different stakeholders and to the public.
Okay, let me just follow up on that, Nicole, with another question. Have you learned anything new during the pandemic from your experiences where you were trying something, but then maybe it wasn't resonating, and perhaps a community member gave some feedback that helped you realize that maybe the messaging needed to be a little bit different? Because we have experienced this at times talking to the community, that it almost takes training to understand how to speak to them, and to decondition, I guess, the science in a way, or the lingo or jargon is sometimes very difficult when that's all you do all day.
Yeah, I mean, I will say, Fort Bend County Health and Human Services, we don't have our own wastewater monitoring program, but we have the great benefit of being partners and collaborating closely with the region, Public Health Region 65 South, as well as with Houston Health Department in Harris County. And as local health authorities, really being able to share that data and collaborate. And we came to really rely heavily on that. And so while we did not use that tactic of a forward-facing dashboard, our local health authority did at times have to brief our electeds and other key decision-making stakeholders on it. And I do think, you just come back to making it really basic and understanding why this science is important, how we use it to allocate resources to inform policy. So that was our experience out in Fort Bend County with using the data.
And the key words for me were know your audience.
Yes, that would be my key takeaway.
Heidi, can I turn to you? Okay, so we also encounter this one. At one point during the presentation, I had a percentage of the number of people we think we're covering with our monitoring program, which is about 16%. If we can get some more major cities in the network, that'll jump pretty quickly. But many people live in areas where their sewage or their waste does not go into a communal system, right? So urban versus rural sampling. And so what do you find are the challenges that face not only wastewater management, but also monitoring in rural areas, say, compared to like big city like Houston?
Right. Yes, and I'd agree. There are definitely unique challenges that face wastewater management and surveillance in an urban situation compared to rural. And while over the last few years, and I guess even longer, we've established our sampling has been focused on urban or peri-urban situations, and we've demonstrated consistently and reliably that we can detect pathogens such as SARS-CoV-2, but there's less known in rural situations. In rural situations are important because these are often the areas that lack clinical testing, either because it's not available or underutilized. In some And some factors to consider in a rural situation are, decentralized systems, such as septic tanks, where the waste is generated and collected near where it's produced. Or rural areas often have a centralized system. However, it's ineffective to monitor for wastewater, either because it lacks the resources, they don't have enough staff, not trained staff, or they often they often consist of a smaller treatment plants, often serve smaller communities, which tend to be spread out geographically, which can lead to economical or logistical difficulties. So I think innovative approaches to implement wastewater sampling in rural or low resource settings are needed in every step of the wastewater process, from sample location, the techniques, the methods, and even things like normalizing the wastewater samples.
Wonderful. Dr. Gerba, you've been working in this space for a number of years. In fact, I think you partially trained with Dr. Melnick. So I showed a picture of Dr. Melnick. And so I think you've seen a few things over the years come and go. Can you talk a little bit about what you have seen historically, what you've experienced, and based on that experience, where you think a lot of this science will go in the future?
Yeah, thank you. Yeah, actually, we made a proposal to DARPA, the defense agency, back in 2007 of doing wastewater-based epidemiology, largely focusing on potentially terrorist events because we could pick it up in the population. And we published a paper on it, but it was decided not to move forward at the time. And believe it or not, about 5 years ago, we proposed it on doing an influenza again of monitoring and predicting types. But fortunately, what happened in January 2020, I had the proposals in my hand, and we went to the university leadership, and they were bid into it as a mechanism of doing it. And just to mention, one of the potentials of doing it was the university calculated, because we did individual dorm monitoring rather than individual testing on a wide scale basis. We didn't have to close the dorms. We were able to find dorms that had a case, tested the individuals, and then isolate them. The university president estimated we saved $100 million by not closing the university. So there's a cost benefit to this and the type of strategy you can use, an incredible saving. You save the cost of all the individual sampling too, and it allows you to be proactive. I think the biggest challenge in the future is developing it as a science. I remember initially the epidemiologists had trouble comprehending how could we use this, was it a value? They were used to individual testing. So I think what's needed in the future is like educational courses in wastewater-based epidemiology, textbooks in it that are in workshops like you're having here, because the science, like you presented excellently, is still evolving. But the epidemiology community and the public health community need to both how to interpret the data and then use the data, I think is the critical point. What I see the potential, as you pointed out very well, is very large for what we could do with this and going forward with it. Just to give you some ideas in not only monitoring wastewater, but we've been trying to develop monitoring swamp areas, marsh areas for insect viruses in the water. Because you don't have to, there are a lot of insects with West Nile virus in the marshlands that they usually catch the insects individually. So there's a potential there to do something with that too. I think it opens, and even other aspects of environmental sampling still can be utilized in specific situations like interventions. I would say one of the things we noticed in our talk is that when we went to mass policy, the amount of positive cases in the dormitories dropped dramatically. We could see it. When we went to stay in place for 2 weeks, it just dropped dramatically, the amount of cases we could detect by wastewater. So there's a lot of potential of interventions. Can we really get good data on interventions? It's interventions we couldn't afford to do before, because if you try to do an individual basis and collect data on individuals in traditional epidemiology. You just can't afford to do it. You need hundreds of thousands of individuals in the data. Now you can monitor them all at one time. So I think interventions is really key how this can be used in the future, or look at looking for papilloma viruses and interventions for cancer vaccines and that, and the efficacy. So I think the potential, we're just at the tip of the iceberg right now of what we can do with this. It's just putting it together and how we're going to use it and educating the next generation.
Yes, and you use two words that provide a perfect segue into Amy,
Yeah.
the word intervention and the word education. So what I'll ask Dr. McGuire is, what may be some of the ethical considerations, some of the messaging complexities that are associated with this science, because it sometimes can be seen as, I was actually told at one point not to use the word surveillance as an example, right? I used the word monitoring and I just used the word surveillance. So what do you see are some of the ethical implications of wastewater-based epidemiology?
Yeah, so I think I'm going to bring up 4 issues and we can dig into them if you want. But so I think there's 4 kind of major issues that I've been thinking about with regard to this. So the first has to do with your comment that, you know, you're capturing 16% of the population. I think the issue of equity is really important to think about. Which percent, who is in that 16% and who's in the remaining group. And really, we talked about sort of the challenges with rural communities, but there's also challenges with under-resourced communities, because in order to do this, you have to have capacity, you have to have buy-in from local governments, and you also have to have sort of the sophisticated understanding of the utility of this or the benefits of this. And so there's a huge role for education to not only for the sake of, you know, educating the public, but also to ensure that you're having equitable representation in the samples that we are collecting so that we can understand the impact on disparate communities. The second issue really has to do with kind of the part that you were talking about, Anthony, with I'm really interested in not the targeted testing you're doing, but also like what would you call it? It's not
Agnostic.
the agnostic testing, right? So you have to decide what you're looking for, right? You can't possibly look at everything. You mentioned the quadrillion viruses that we're finding. So how do you determine targets? And actually the National Academy's report, I think, does a really good idea of sort of setting out a framework for prioritizing different targets. And they talk about looking at evaluating targets based on their public health significance, the analytic feasibility of monitoring the targets in wastewater, and then the usefulness of the wastewater data in informing public health action. So that sounds simple, but I'm sure it's not very simple to implement, but at least it gives us a framework to think about how are we going to choose the targets that we're going to be focused on. The third issue has to do with the fact that it is possible actually to capture human DNA within wastewater. We came up, you know, this became a huge issue when we were doing the human microbiome project, where we thought we were just sequencing all the microbes in our body. And then we were like, oops, there's actually human contamination in here and we have human DNA. And what do we do with that data? And do we release it? And how do we protect privacy and all those sorts of things? So that has obviously some very significant implications in terms of, can you in the future potentially identify individuals from the community level wastewater, from their human DNA? Can you find out all kinds of sensitive information about them? And most importantly, what do we do with that information and how do we protect individuals and their privacy? And then finally, the last ethical issue that I've been thinking a little bit about has to do with this idea of what do we communicate to the public? And I generally think transparency is really, really important for public trust. But there is sort of a countervailing concern about community stigma. And that agnostic testing that we're doing, we don't know what we're going to find in it. And we know that we can find all kinds of things, right? We can track sort of stigmatizing diseases like HIV prevalence in communities. We can look at illicit drug use. We can look at alcohol use. We can look at all kinds of things that might be stigmatizing to communities. And one of the things that I've been really interested in, I didn't even think about this, was that when one of my colleagues was talking to community members about this, their major concern was around property value. Right. So is the property value of my house going to decrease if there's high prevalence of HIV or something like that in our particular community? So I think we need to kind of think about what we report to the public and how we do it, but also what impact that might have on different communities and how they respond to that. And for me, one of the key features of that is really doing much more community engagement around that.
Yeah, excellent. Thank you. So we've had a scheduled round of questions for the panelists to help you get introduced to them and their expertise. These are some of the bigger questions that often arise when thinking about this field. But now I'd like to open it up to the floor here. No question is inappropriate or not going to be respected. So please feel free to speak up, and we'll do our best to provide some answers. Tony, did you want to go first?
And I think this would be directed to everyone, but in particular, Amy. There's a strong vocal minority group of anti-science, and with the issue of intrusion into their private life. And I wonder, how do we get ahead of this as one expands these type of programs?
Yeah, really great question. So I think the last part of what I said, probably, let me reiterate. I think community engagement, like true community engagement early on, is really, really, really essential. And I know that TEPHI is doing some of that, but I think it's incredibly important work, because from where I sit, the worst case scenario is when we're doing all this really cool science and nobody really knows about it or understands it. And then it blows up in the media. And then all of a sudden people, you've been surveilling my wastewater? What? How did I not know about this? What are you doing with this information? How dare you? That's my, and so we don't want that. So really sort of letting people know what we're doing, what we're hoping to do, what we're planning to do, getting their input on it. What are your concerns about it? How can we address those concerns in responsible ways, et cetera, I think is, it's challenging, but it's essential to the work that we do. I don't know if others have thoughts.
No, I really echo your sentiments on a couple of things: transparency, community, sustained community engagement, and explaining the utility really clearly of the science. And I thought about the use in Houston Independent School District monitoring, and really being able to explain to the stakeholders, right, the educators, the parents, why this data could be useful in understanding what's happening with this health forecast, if you will, of their school community. So really, I think those are, again, you really highlight the importance of excellent communication in that public health space.
Thank you. And let me say two more things. So one is, I think it's really important also to be clear about the purpose of what we're doing and what we're doing with the data, right? So there's at least 3 things we could do with the data, right? There's the public health interventions, there's the research, and then there's sort of criminal use of the data, right? Which we're not doing, but I think people are concerned about. Like, is law enforcement going to access this and see if there's like illicit drug use? Can they trace it back to my building? Can they trace it back to my apartment? What are they trying to do with this information? So I think it's incumbent on us as scientists to be really clear about this is what we are and will not ever do, or where we're drawing lines and how solid those lines are. And then I think we really need to understand sort of how the community feels about this. It's interesting. I was talking to my son who's 23 and a student, a master's student last night, and I was telling him I was giving this talk, and he initially I'm telling him about wastewater surveillance, and he's like really interested, and he's like, well, I don't have a problem with that. It's just like the whole community, right? And I was like, yeah. And I was like, but during COVID, they were doing wastewater surveillance on dorms and schools. And you're like, wait a minute, I'm not okay with that. And I was like, that's interesting. Why is your line there? And I think kind of understanding that from different people is really important. Like, where do people start to get uncomfortable with this, and why? So I don't know if we have enough information about that yet.
I think in some surveys I've seen, that has been the concern, actually, that it will be used to shut down a business or a school or used in a way like that. And I thought privacy would be the number one thing, but it turns out, looks like many of them don't even really often understand what is possible with it. And so that doesn't come up as a concern.
Right.
They're
concerned about intrusions on their civil liberties.
Yes.
So you find this, are you going to make me isolate? Are you going to make me, I think that's one of the concerns. Like, what are you going to do with this information, and how is it going to impact my rights, my liberties? my freedom, right?
Thank you, Tony.
Good morning, everyone. My name is Ron Bhattacharjee from Houston Health Department. I have a question to the panel, and thank you, panel, for giving your time to us. What are the three major negative effects of contaminating water with human wastewater?
Can you say it again? I missed it.
What are the three main negative effects of contaminating water with human wastewater?
Oh, contamination.
Yeah.
I think Dr. Gerba can talk a lot about this one. We'll pass it to him.
Yeah.
He loves this one.
Well, of course, you probably know in terms of water quality, in that, there are regulations for drinking water utilities that have to monitor on a regular basis of it, but it depends on your source of water too. In rural areas, groundwater is a big issue. In groundwater contamination with viruses and chemicals, of course, is the issue that we deal with. The big issue, and some of it overlaps what we were talking about, is wastewater reuse, which is taking place in Texas and Arizona, going to a large scale for taking wastewater and then actually making it into a drinking water. And that takes a lot of public trust. We were talking about, and I maybe as an example of this, and since you brought that up, is like my facility is located right next to a wastewater treatment plant for the reason they wanted a university research center next to the facility that they're going to eventually reuse the wastewater and eventually it'll go toilet to tap. And they wanted to build confidence in the public that we're looking to the future, and then all the questions you have, we're going to respond to them. And when it comes to time to do this to potable reuse, we've studied it for 20 years. We have a university team on site that can answer your questions and we give tours and all this. And a lot of this goes back to is to build a public confidence. Like I'm on the with the state, the public outreach, where we give regular communications on this, and we have meetings with the public to determine what are their issues, what are they concerned about. But monitoring for pathogens in wastewater is challenging. I think that's where you were going with that. The technology is available, but it's costly. We largely rely on bacterial standards right now. But when we're going to advanced wastewater treatment for reuse, the other testing is coming into play for viruses and parasites in that. So I think that's where that's going. But all we would like, we tried systems where we would monitor the distribution systems in satellite communities where at different places, our distribution, so they automatically tested the water for bacteria and sent, or chemicals in the water, and sent it back to a central laboratory on a regular process. The problem with that was maintenance of these. We had a half a dozen, but somebody had to keep almost on a continuous basis, go out and maintain them, furnish them with the chemicals needed, and then the system would go out. So I don't know, I think at least a few years ago, the technology wasn't really there for this remote monitoring because it required too much maintenance for the distribution system and that. And I think the time will come when it'll be feasible, but maintenance of those systems is really costly and time consuming for a utility. It's really not practical on a large scale to monitor the water within distribution systems with the technology we currently have. I hope I answered your question.
Oh, over here. Hi, Lauren Stadler from Rice University. This is a question for Dr. Gerba, but all the other panelists as well. It's about, as we think about, the next potential pandemic, are there other places you think we should be prioritizing monitoring, maybe outside of human wastewater, especially if we think about maybe animal reservoirs, or we might expect to see these spillover events? And then, so I guess my question is, where should we be monitoring? How do we prioritize that? And then if you could comment on the status of the science in that space.
If I get the question, what else could we monitor for?
Yes, especially to detect maybe these, spillover events where you have a animal, virus or pathogen hop over to human.
What's kind of interesting is we monitor for plant pathogens. I can actually tell you what the dominant diet is in a community by looking at the plant pathogens, because a salsa that you put on it can contain 1 million pepper viruses per milliliter. They're loaded with it. And then you get the cucumber viruses, you get tobacco viruses. We can tell you how much smoking is going on by looking at the tobacco mosaic viruses in there. So we look at those largely to get an idea of they're difficult to remove during water and wastewater treatment. So we look at them as potential indicators in that. So you can actually get at dietary habits. You could actually look at the food particles and actually determine what the major diets people have. There's a paper recently I reviewed where they're looking at diets of people in different regions of the world, and they can tell that by the wastewater. So there's a lot of potential for other things, dietary things. We can determine, for example, I think you mentioned it too, some of the more resistant viruses like herpes viruses, you can find that in wastewater in that. So the whole range of looking for viruses is quite interesting. We do also look a lot for bacterial viruses and try to look at the types that are occurring as potential rapid indicators of treatment performance for water and wastewater systems, because they can be analyzed, at least from an infection to rather quickly. One of the big limitations with the molecular methods, we can't determine whether these viruses are infectious or not. That would be really something that would be useful from the standpoint of water reuse in that, from what they're looking at it too. But there's a potential of mostly, I mean, our group has a t-shirt we call Sewage Never Lies, because you can find out so much information about what's going on in a community. And of course, that brings up your ethical issues too. But if we know it exists, we can find it. And we're actually coming across viruses, and you've seen them too. We don't know what they cause. They're actually human sources. We can detect some of them in cell cultures, but we haven't yet identified them. It's estimated that there are about 100,000 to 500,000 viruses yet to be discovered that could infect humans. So, there's a lot of range, and given this technology, and because of the large monitoring of wastewater, we're coming across things we hadn't seen before, at least in our work and that. So there's a huge potential for discovery. Yeah.
Lauren, did you mean mostly wastewater from other reservoirs, like agricultural?
Oh, yeah.
Yes, just monitoring. Yes.
That's a good point. You could actually monitor plant pathogens. In other words, what's the incidence of pepper virus in this field by looking at the runoff from the field. Usually when they irrigate water, the excess water is discharged or goes into a canal. By testing that, you could find out the incidence of whether you have a pepper virus, whether you have certain insects in the field, because the insects all have viruses that feed on plants. So you do have a potential large for agriculture. You can monitor for animal viruses like cattle viruses. They get very frequently, and look what's coming from runoff from fields and what the cattle are actually infected with by monitoring the water. And I think there's a potential for plant viruses too, and looking at area-wide incidences of plant viruses in that too. So there's a lot of potential for monitoring water systems outside of wastewater and learning what's going on, what animals, you could probably even look for, get an idea like how many woodpeckers are in a field, for example. If you're looking for an endangered species, the potential is there for monitoring endangered species incidents, occurrence, and changes in populations by monitoring the watershed from an area. So the potential is large.
I would add, so arthropods, Lyme for Lyme and arboviruses, for example, avian and swine, so birds and pigs, because we know influenzas can mix and match in there and then jump. Obviously bats. We didn't learn our lesson already. Actually, people already knew that. We just weren't doing it at high enough level. And then I wrote down one that's not thought of that maybe we should consider as companion pets. There's a lot of evidence that we exchange bacterial antibiotic resistance genes, E. coli and Pseudomonas staph, with our pets. So companion pets can be a source of transmission to your gastrointestinal tract, and you can get infected with an animal causing organism because of this. So you mentioned plants, and I just threw a few animal and insect vectors that I thought. Tony may have other ideas. I don't know. He thinks about these sometimes. Rodent. Tom, was there another?
Right here. Hi, Erica Brown, Harris County Public Health. I want to go back a moment to the conversation around what we do with the data and community engagement, and really pose a question of thought for all of us of how do we engage in advocacy at the local and federal level for perhaps legal guidelines, perhaps bills for our state at a national level as well. Because when I think about the wonderful science of this, and then I translate that to the wonderful science, for instance, of social media, of AI, of risk adjusters for insurance. We just heard about, I can tell you how much tobacco is used in a community. I can tell you how much HIV is in a community. And from a scientific perspective, for all of us, these are wonderful things to know, to do good with. But then there's also the other side, of which I'm not suggesting that it's not good, it's not necessary, but it is a statement of fact that it can very easily disenfranchise those who are already disenfranchised in these communities that are already inequitable. And so I wonder, have we thought about, are there already work groups, again, at the local, at the national levels with our public health groups that are working on perhaps legislation that could give guidance to how we use this data, and we can learn from some of the lessons, again, of social media, where we are today. Even things as simple as Alexa. Alexa came in, everybody said, oh, great, Alexa, turn my lights on. But oh, by the way, Alexa recorded everything you said, and now can it be used in a court of law? We didn't think about that. So we have some historical knowledge of some of the gaps in what we should be thinking of, and should we be using that information to pre-plan, to engage with the community about their concerns, and to design a framework so that we can, as best as possible, assure security of that data.
Cool. Maybe new.
I can speak, but if anyone has anything else. So I think as in most areas of innovation, I was gonna say innovative science, but innovation in general, the policy lags, which is always not the greatest place to be. So I think there's a lot of work that needs to be done. And, we've looked, I think there's a lot of sort of regulation that could be useful in this space. I think some of the most interesting to me open questions are around law enforcement access to this information. And we've looked at we're doing some projects on law enforcement access to like commercial genetic information and other ways in which law enforcement engages with health and research and commercial information, and in positive and negative ways. So we're hoping to look into that a little bit. But I do think that there is a lot of room for both sort of thinking about the ethics of the field of wastewater surveillance, as well as thinking about the laws, policies, and regulations at all levels. You could go everything from federal law, which is in today's environment hard to get consensus on. There's state level laws, and then there's also policies. There could be Department of Health policies. There could be, sort of policies that are put in place at the local or municipal level that can help sort of draw the boundaries around what is going to be acceptable and what's not. And those should be informed by the community.
I think there's time for one more from the audience in the room. Tom, did you have? Or was there another?
Maybe a bit of a technical question, but there's a lot of pathogens that are in animals and humans at the same time, same exact pathogen. How do you distinguish that? And sort of related to that, does the wastewater sampling, is it limited to sewage only, or what about storm runoff, and how often does that get mixed in there? Because, you know, birds and other animals, viruses and pathogens are going to be reflected more in that stream.
Heidi, do you want to go first? Yeah. Well, runoff, we do see some strange things in the signal. Rodent, for example, lots of rodent viruses, bird viruses, elephant viruses. It's clear that that's coming from the zoo. So it does, these, you know, so these things do make their way into some of the catchment areas. How, you know, I'm not really at liberty to say. I think that might be a good question for the afternoon panelists that think more about that, but.
You know, I would say avian flu is an intestinal. And I remember when I worked at Baylor, isolating influenza from the ponds in north where the birds, migrating birds would settle, and you had no trouble finding bird influenza in the water. So some people suggested you could monitor the water where migrating birds go and look at the movement of influenza in the water. But anyway, place you find large numbers of migrating birds, you almost always find in the wintertime influenza virus in the water. So it's a way of monitoring potentially zoonotic diseases, you know, monitoring the in water environment of these animals and determining what potential they have. The same thing with bats. I didn't realize bats, a lot of them like to go in trees over the water in some parts of the world. And you can find a lot of bat viruses, reoviruses in the water underneath where bats roost, for example, which could potentially, well, are known to potentially could infect humans.
I think Tom, I think other waterways are, you know, should be tapped too. Right. Like the bayou, for example, we survey that as well, and we see drug-resistant Pseudomonas in there. That's very similar to what's coming out of people in the Texas Medical Center, as an example.
I wonder if you built a periodic sampling of the storm runoff, then you could subtract out what you know is in the natural environment from what is in the human stream, and kind of arrive at some way to distinguish human from animal reservoirs.
Okay, if there's no one else in the room, maybe is there anyone? Maybe one more time, Mariana, and while you're doing it, I'll see what I can dig up online.
Oh, thank you. Thank you to the panelists. Super interesting conversation. I was just curious how this team has been kind of thinking about wastewater data management in general. And what I mean by that is there's almost like you can think about it as another type of clinical data, where the clinical data has a lot of regulation and guards, and accessing it is not easy. There's a lot of permission required. And then, so that's one extreme where we could think about wastewater data really as like clinical data and use similar approaches, even though there are no laws, you know, kind of treat it like that. And then on the other extreme, thinking about wastewater data more as like environmental data or like weather data, you know, where that is more accessible and like shareable between parties, between institutions, to the public. I'm just curious if this team, kind of how is this team thinking about it? Because I definitely have come across just different philosophies as the field continues to evolve. And just curious if there's any initial thoughts from the team, or still a very active conversation maybe.
No, I was going to say that's a Fabulous question, Mariana. And I, in my role have not been in those conversations. So I'm really interested in hearing what anyone else has seen and even you, Mariana, in your role, with your company.
Yeah, I don't have a good answer. I think it's a really, really, really important question because how there's different regulatory frameworks depending on how you treat the data. And there's probably a Venn diagram of how we think about this, right? Even within treating it as health data, if it's public health data, right? Community level public health data versus individual health data versus research data versus, the fact that we're collecting these data without IRBs, without consent, suggests we're not treating it as research data, or at least, identifiable research data. But should we be, as we start to understand more about the potential to be able to trace back to individual households or even individuals themselves and what kind of information we can have. And also the importance of, and we heard several times already this morning, the importance of really collecting orthogonal data that you can combine with this. And then that becomes much more powerful at both the community and the individual level. So does that change how we think about the data and how we treat the data? It's a really important question that I don't think anyone has satisfactorily answered. I've seen a paper or two that's been like, well, we could think about it from this framework and we could think about it from this framework and we can think about it from this framework, but it doesn't clearly fit in any one framework that we currently have. So how do we manage that?
And I agree, it's a very good question. And at the state level, I think we treat it more as environmental data. And our idea is to share it with the locals, and so they can share it with their communities. And that may also help address the disenfranchised communities because they know that the best.
We should probably move to the online now. We only have 10 minutes left, right, Janelle? I think they're going to be read from the back.
Yes. So we have a couple of questions, and one of them is, does wastewater management and applied virology and microbiology science impact the prevalence of birth defects or birth complications? And if so, how so? And has anyone researched the difference in rural and urban settings?
This is certainly one I have never encountered. Chuck?
Well, the issue probably might be with like the Coxsackie viruses with B5, they infect the pregnant individual and then they can cause meningitis or a problem with meningitis. There's a few other disease. Coxsackie sticks out his mind as the problem with, by monitoring, you get an idea of the incidence. Coxsackie B5 is actually one of the most common viruses you isolate in wastewater. Whether you can attribute that always to the cases of meningitis in pregnant individuals, I'm not sure, but there are a few viruses like that I'm aware of that largely can be transferred to the unborn child. Or you could look for toxoplasmosis too. Would be another one you could look for.
Listeria.
Or listeria. Listeria is another potential one too. Relating that, to relate that to an issue, you would probably have to sample the wastewater from a hospital or clinic or something, because you would lose it in the background area. But it could be one that could be done in a facility scale, whether, there might be legal issues with that too. But
and we do detect those viruses by the complete sequencing method.
Okay, I think we can squeeze in a couple more. Please explain how this concept can help with tuberculosis surveillance in the community. How can it be used to aid the drive to TB elimination?
Maybe you want to answer that too, but that's a good question. That topic has come up, but I haven't seen much reported on that lately. I don't know if you've seen it.
Well, I think it's so if you look at TB prevalence in this country, it's actually not very prevalent. In other countries, for example, in Africa, it's very prevalent, right? And so in a developed country, there is you hit a wall at what level you can further make grounds with identifying transmissible infected individuals, right? So all the measures in place get you to a certain percentage, and you can't really break more ground with current surveillance or monitoring techniques. And so I think with TB in particular, and I would argue with HIV, in developed countries, it's to be able to light that cryptic transmission. There's 20 to 30% HIV transmission with, a small number of people, and we don't really know where they are or what time of the year they're transmitting them. And I think if you knew where these low level transmissions, which really sustains the pathogen long term, then you can target educational or other measures to that area and perhaps make a further dent. I think in developing countries, it would be much more impactful because you're working with a lot more infected people, and so the impact you can have, the delta can be greater. So, there's a lot of cryptic transmission for infectious diseases that I think can be picked up by wastewater, and it's just figuring out at what level that is occurring at and whether or not we can have targeted interventions in those areas to help push that that barrier further down.
What is the current practice when it comes to hazardous waste that come from disposal of tobacco products like cigarettes or e-cigarettes, which don't really have a specific guidelines for disposal?
We don't see any nicotine in our analysis. That was a joke. That was a
I
joke.
don't really have it.
I don't know, Chuck. Have you counted that?
I
It's
mean,
just people
We have
flushing it
another-
down a toilet.
looked at the back of different communities, but nobody's gone any further
Yeah.
than that. It is actually a really tough virus. It survives the wastewater treatment really well, one of the more hardy viruses. But I can't tell you much more than that.
So you're detecting tobacco virus?
Oh, yeah, tobacco mosaic virus.
No, that was a joke. It's just a chemical combo. You'd use a mass spectrometry, completely different technique. Yeah. That's a good question. That's difficult to answer.
What is the approach you use to sequence human adenovirus recovered from wastewater? Targeted genomic sequencing, question mark?
No, it's whole genome. It says we capture viral sequences with a probe capture set that's designed against 3,500 mammalian viruses. This allows for us to enrich amongst the background of all the competing nucleic acids that are in there. There's a lot of bacterial DNA and there's some human DNA. And then it's just Illumina NovaSeq after library prep from that point forward. So if we have high levels of viruses and probe capture is good and amplification for the sequence occurs well, we expect that we'll get enough reads to be able to cover most of the genomes. I think we have a cutoff of 10%. If we don't see more than 10%, even though it's probably still possible to some degree to identify a virus, we have less confidence in the data. And you saw for some of the data I put up there that for the most prevalent viruses or those that are present in high concentrations and or amplify very well based on the platform and technology, we get 99% coverage, which then allows us very easily to identify even SNPs and viral type and more sophisticated things like that. It's probably a little more technical than we want for maybe general audience, but that's how we do it.
Adenovirus are one of the most stable viruses around and one of the most common frequently. Recent study found 70% of public restrooms have adenoviruses on their surfaces. And we did a thing on self-checkout screens at grocery stores, and about 25% have adenoviruses on them. So you're continually exposed to adenovirus. But I think they're really stable because they're double-stranded DNA.
I think I have one more question to wrap it up. Last is, I would agree that targeted public health actions should not necessarily be the end product of all wastewater-based epidemiology. Wastewater surveillance can be used to complement other public health surveillance to help ensure or confirm the absence of cases as well as the presence of cases. Any thoughts on that?
Just that I agree. And that's, as a scientist, I'm a trained molecular scientist, and we follow the data, the evidence comes first. And when you could validate a signal by 2 or 3 different mechanisms or means, then that's more believable. It gives you the ability to have some confidence in the statement you're making. And that is why in our program, for example, we have 2 orthogonal ways that are very different to do it, that sometimes arrive at the same question, but then we have a clinical data set that we're available, try to cross-reference to as well. Those are, really important pieces to be able to say that, you have an outbreak or you have an upswing in cases or cryptic transmission or whatever. I don't know if anyone else wants. This is probably our last question, so maybe we can have a closing thought on this idea or a related one from everyone, briefly, a minute.
More than agree.
More than agree. Okay. Yeah. Nicole?
I'll start. Yeah.
Or Heidi?
So, yeah, I agree with that statement. I think it's one piece in the puzzle or one piece of evidence that really so you need everything together to have a good picture. So the clinical data, the environmental data, the wastewater data.
Yeah, no, and I agree that, from what I've learned about the technology and the data is that it's an important part of the toolkit as we look at other surveillance indicators. And so I come from clinical medicine, right? So looking at those clinical indicators is something that I'm comfortable with, whether it be the hospitalization, the case rates, those typical indicators in epidemiology. But this is, it complements that nicely. It's I think, a critical part of that toolkit.
No.
I mean, again, I also agree. I think, as somebody who's interested in data science also, I think, this is an incredibly exciting and powerful tool to add to that toolkit. I think with sort of the advancements that we're seeing in AI technology as well, and how we combine all of these data, it certainly will keep me in business for a very long time, but thinking about sort of how we do that in ways that benefit public health, benefit public interest, and also protect individual privacy, liberties, considerations, I think is really critical to this. So, but I think it's a very exciting time, and I've really, really enjoyed learning more about the science of how this works, because I think it has the potential to really transform how we do a lot of our public health efforts.
I'd say finally it gives us a tool on intervention. I've seen papers now where they're trying interventions to reduce the number of hospital-acquired and antibiotic-resistant bacteria, and they showed their intervention worked. So you have a very low-cost tool to measure interventions, and I think interventions in business buildings. Is it really worthwhile putting all that ventilation and doing all that disinfectant? Do we reduce the amount of people that are carrying it, both symptomatic and the big tool is it gives us the asymptomatic people, which we didn't have before. And that can tell you a lot with an intervention. If the asymptomatics go down, even if you have no cases, your intervention worked. So the intervention technology to me is huge. We can monitor and determine the success of interventions we could never do before based on traditional epidemiology. So that's a big benefit.
Good. Thank you. Thank you, Dr. Maresso, panelists, for that insightful and engaging discussion. Thank you. This really highlights that there are many factors to consider as the field of wastewater science continues to grow, both with the potential advances in technology and with respect to ethical concerns. So, thank you very much for being here. Now I would like to invite Dr. Kristina Mena to the podium to present the inaugural Friends of TEPHI Award. And this is very exciting. So thank you, Dr. Mena.
Oh, so thank you. So the year was 1975. Gerald Ford was our president. Mood rings and Rubik's Cubes were all the rage. and Saturday Night Live debuted on NBC. In addition, the paper Microbiological Hazards of Household Toilets headlined the Journal of Applied Microbiology, which was led by Professor Chuck Gerba. So Professor Gerba, you are the reason we are all here today at the summit, and we thank you for your contributions to the field of environmental microbiology and epidemiology. Would you please come forward? I am honored to present to you the inaugural Friends of TEPHI Award. It says Professor Charles P. Gerba, Dr. Germ, the Friends of TEPHI Award for his visionary contributions to the fields of microbiology and environmental health, awarded today, October 19th, 2023.
Oh, great. Thank you. Oh, yeah. I always like to tell everybody my career started in the toilet. And I looked at the horizon, what was above the toilet seat, and I said, is to stop right there for doing it. But actually, I owe a lot of credit to Dr. Melnick, who was the department head. He tried to talk everybody into studying the potential disease spread by toilets, and nobody ever took it up on him except me. And that's how I actually got started with it, because he was curious how poliovirus could spread in developed countries when it was not spread by aerosols, and he thought the restroom was the way to do it. But one thing I learned, those days I had a mouth pipette out of the toilet, and my biggest fear was getting the hiccups when we did it on that. But my role was monitoring all the toilets at in the Department of Virology, believe it or not. But that's how we started out in looking at this field in the potential beginning. And thank you very much.
No, thank you. And so yes, I'll just add. So the field of toilet epidemiology was born from Dr. Chuck Gerba, and those of us, myself, Dr. Kelly Reynolds, who had the tremendous opportunity to study under your tutelage. I'll share with you, we were required to bring in our worn underwear for his infamous laundry studies. We had to share any personal bouts of diarrhea with our colleagues, and also agree to have any items that within our personal space sampled for pathogens. But thank you for your guidance and mentorship that launched our careers. So with that, let's all enjoy lunch together. Then let's go make some more wastewater. And remember, when entering a public restroom, always choose the first stall. And if you want to know why, just ask Chuck Gerba. So thank you very much.